Well, the problem with the optic nerve and with the rest of the nervous system is it's not so much that you need these nerve cells to grow. They have to grow in the right place and connect with the right nerve cells. So it's complicated.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 85 of the Strokecast. You know, I'm always saying there is nothing wrong with my arm, and there is nothing wrong with my leg. The problem is literally all in my head. The stroke damaged the parts of my brain that control the motion in my limbs, and that's why they don't work, because I can't talk effectively to them. The problem is literally that chunk of dead brain tissue in the middle of my head. After a stroke, what we can do, or what we're able to do while we're recovering, really depends entirely on exactly where the stroke was in our brain, what systems it affected, and how severe it was. And sometimes the part of the brain that gets affected is the part that controls those limbs, as in my case. Sometimes, though, the part of the brain that gets affected is the part that controls vision or manages vision. Because what we think of as vision is really about the intersection of the eye and the brain. Vision only exists when both of those parts of the system are working properly. After a stroke, it's not uncommon for the visual cortex to be damaged, for the part of the brain to be damaged that can process images. So it's entirely possible to have two eyes that work perfectly well and that send perfect data to the brain and to not be able to see because the brain no longer knows what to do with that incoming data. Other things that can get damaged include the muscles that control the eyes, or rather, the part of the brain that controls the muscles that aim the eyes. And when that happens, we may not be able to keep our eyes steady or aimed in the proper direction. And again, we experience vision problems. All of these different systems have to work together. And that's where neuro-ophthalmologists come in. Dr. Eugene May has been a neuro-ophthalmologist in the Seattle area since 1992. And now he's with, well, I guess my favorite hospital, Swedish Medical Center, the only hospital I've ever spent significant time in. A couple of weeks ago, Dr. May and I sat down to talk about his specialty and this field and what it really means for stroke survivors. And it was a fascinating chat. This area, this whole question of how the brain handles this data and how we create vision in our heads it's terrifying for what can go wrong, and it's amazing for how it can go right. And it's fascinating to look at how all of these different things come together. And on top of it, Dr. Eugene May has one of the best voices out there for podcasts. So with that in mind, let's go ahead and meet Dr. Eugene May.
But there are some neuro-ophthalmologists who are actually ophthalmologists first, and then go get their secondary training in neurology. But we see people with the entire spectrum of neurologic conditions. So much of the brain is involved in visual processing and eye movements that it's really not surprising that almost any neurologic condition in some form may affect vision. So I know we're going to talk a lot about strokes today, but strokes very frequently cause visual symptoms. People with brain tumors and multiple sclerosis and aneurysms and various types of degenerative conditions like Parkinson's disease and Alzheimer's disease in some shape or form frequently have visual problems. And when those patients who have known neurologic conditions develop visual issues, they frequently are referred to us to help us define what the visual problem is and to hopefully help people deal with that problem or overcome it. Excuse me. Sometimes we see people before they're diagnosed with neurologic conditions, and they have visual symptoms that an ophthalmologist or optometrist does not believe is due to an eye problem, and then they get referred to us because of a potential neurologic problem. And then we may be the docs who diagnose the neurologic problem based on a visual symptom. That can occur with stroke, too.
Interesting. I mean, there's so much, I think, the general public sees as if the eye is physically working, then vision is fine, or you can put a pair of glasses in front of it and it's fine. But that's really just the small front end of a really complex system.
That's exactly right. And that's frequently how people wind up being referred to us, is they have a prominent visual symptom. They see an eye doc. The eye doc looks at the eye and says, everything looks fine, so it must be something behind the eye.
That's also one of those real important examples of why we're seeing the evolution of the FAST acronym for stroke warning to the BFAST to incorporate, balance, and to also incorporate the vision changes that go along with that.
That's right. Yep. Strokes can affect the brain, and strokes can affect the eye itself in a way. So sometimes people who are having the equivalent of a stroke experience loss of blood flow to one of their eyes. And that's the same as having a stroke in the brain. And so eye doctors are very aware of this issue. Frequently people come in when they lose vision just in one eye, and they get the same treatment that a person would get if they had a bona fide full-fledged stroke in the brain.
That makes a lot of sense when you think about it. Those cells in the eye need blood flow, need oxygen, need nutrients, and when a clot blocks that, those cells are going to die off and be less functional, whether that's in the eye itself or in the optic nerve.
That's right. And the blood flow to the eye is the same as the blood flow to the brain. They share arteries. And so the same processes that cause narrowing of the arteries to the brain affect the eye as well. If blood clots come, for example, from the heart, may go towards the brain, but may go towards the eye itself.
And everything's got to come up through those carotid arteries. And one of the things that causes, I know, a lot of strokes in younger survivors is the vertebral artery dissections, which start throwing clots around, which can also impact that.
Mm-hmm.
It's really interesting. One of the things that we're talking more about, and I think more people are starting to understand, is we normally think of stroke as it's a problem of the brain and it's a problem of the nerves. And really, that's the result of the stroke. It's actually all a problem of the circulatory system. It's the same thing that leads to a heart attack, that leads to a stroke, that will lead to an ocular stroke in this case.
Exactly. And the way neurologists think about that in kind of a different way is that all of neurology has to do with location. So when a person has a stroke, that's an indicator of some problem in the circulatory system, blockage of an artery, blood clot coming from the heart, damage to an artery. But the end result is a neurologic or visual symptom that totally depends on the location of the blood flow problem. So, for example, the visual pathways in the brain are localized one side or the other, just like the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. It's the left side of the brain that sees the right side of the world in each eye, and it's the right side of the brain that sees the left side of the world in each eye. So if a stroke occurs in the right side of the brain, if it affects the visual pathways, then a person may lose vision on the left half of their vision in each eye. So when we see a patient with that type of vision loss, we can pretty accurately say where the stroke occurred. Similarly, the eye movement pathways, the part of the brain that we use to control the way our eyes move, are all in the base of the brain, in the brainstem and the cerebellum. So when people have strokes that involve the brainstem or the cerebellum, they're usually fairly characteristic eye movement abnormalities that result. And those can cause a number of different symptoms, including double vision, vertigo, or what we call oscillopsia, where a person looks at something and it seems to oscillate side to side or up and down. And we can usually tell by looking at the eye movement abnormality and finding out what the patient's symptoms are, where in the brainstem or cerebellum the stroke occurred. So in neurology, and particularly with strokes, it's all very real estate specific. So whatever happens with a particular blood vessel, the symptom that a person's going to have is based on where the blockage of blood flow is.
Yeah, because all of that, when we talk about things, the more obvious symptoms from the outside that we think about with, drooping limbs, drooping face, that's because muscles aren't getting the signal. And in the case of the eye, there's muscles. Every time you turn your eyes, you're using eye muscles to do that. And those muscles can absolutely be impacted by a stroke.
That's right, because it's your brain that commands those muscles to do the right thing. And if there's an injury to whatever part of the brain is directing the eye muscles, then the eye muscles are going to go out of line or may just start oscillating spontaneously.
Interesting. And oscillating would be like when one of the muscles starts pulling it slightly away, maybe sort of like what we think of in clonus in a foot or an arm, when my arm just starts vibrating.
Yeah, in a way, yeah. The specific finding is what we call nystagmus. And that is when a person can't hold their eyes still. And the eyes tend to oscillate in one direction or another, sometimes side to side, sometimes up and down. And so the symptom is of blurred vision, where either it's out of focus or it's what you're looking at seems to be moving. But the finding when we examine a patient is that the eyes are repetitively moving. And that's what's called nystagmus. And that's one of the many findings that you see when a person has a stroke in the brainstem or the cerebellum.
So in your path, you started in neurology and then went into neuro-ophthalmology specifically.
Correct. Yep.
What really drove that transition? Was there a specific aspect of your neurological study?
I was mostly interested in eye movements and how the brain controls eye movements. And it's pretty remarkable that there's a limited number of nerve cells in the base of the brain that more or less completely controls the way we use our eyes and the way we use them together. I worked in a lab when I was in medical school that studied a certain group of those nerve cells in squirrel monkeys. Particularly, the type of eye movement we were studying was the eye movement that we make when our heads are moving, but we want to keep our eyes fixed on a target that's moving with our head. I mean, it's not as easy as it sounds. To keep your eye focused on something that's moving with you is a pretty complex act. But there are probably only a few hundred nerve cells in the brainstem that allow us to do that. And that was the eye movement pathway that I was studying in medical school. At the time I was learning about other eye movement control pathways as well that are kind of equally fascinating. And it was exciting being a part of learning about that. It's helped, over the past few decades in my practice, looking at patients, trying to figure out what's wrong with the way they move their eyes, and then deciding what to do about it.
That's one of those areas, too, which it has all sorts of other implications. I mean, outside of your specialty, when we start talking about what we're seeing in artificial intelligence and machine learning and robotics, there's a lot of that goes on there with tracking what you're doing in your environment while moving, while trying to maintain stability.
Right, exactly.
Yeah. Mm-hmm. And the other thing is, when we talk about brain stems and the cerebellum, evolutionarily, those are also the more basic parts of the brain, the ones we share with more and more critters on Earth.
Right.
So that have those more basic fundamental functions that are so complex, even in the simplest critters.
Mm-hmm. That's right. Yep.
When are patients most likely to engage with a neuro-ophthalmologist then? Do they generally come to the field because they're having problems, or because they've already had the stroke, or what is that general pathway for patients to get to you?
I would say that we see, of all the stroke patients that we see, I would say maybe about a quarter of them are people that we diagnose with the stroke. They have a visual symptom, they see their eye doctor, the eye doctor is suspicious that it's not an eye problem, and then they refer them to us. We make the diagnosis of the stroke and then refer them on for management or for long-term care, for risk factor management to minimize future stroke risk. The other 75% are people who've already had a stroke and are having ongoing visual symptoms. And our responsibility at that point is to, as best as possible, define what the visual problem is and determine what to do about it to make a person more functional or kind of assist in their recovery.
And what sorts of things are you able to do to help people become more functional and to recover more? Is it, is it more physical procedures? Is it neurological training? What do that typically look like?
Well, it kind of depends on what the problem is. So, like we talked about before, the two main groups of stroke patients that we see, one is the group of patients who have strokes in their visual pathways in the brain that give them what we call visual field defects, where there are areas in their vision that they can't see, usually on one side or the other. So that's what we would consider a visual field defect. For people who get a visual field defect after a stroke, like more or less for most other stroke symptoms, the first thing we do is just wait. You wait to see how much better is it going to get. Some people get better with visual field defects and some people don't, just like with all other stroke symptoms. So we generally kind of urge people just kind of cool off and wait and wait and wait. And then once it's clear that they have a certain persistent visual field defect, then we start intervening. First and foremost, the main issue is safety. So when people can only see half of the world, then they're missing stuff. And when they're up and around, they may have a tendency to run into things or trip over things. And in a lot of those cases, when you're talking about that visual field defect, it's happening in the brain. So it's not that they have trouble seeing. The information is all getting in there, but the brain is just disregarding that information in the field. That's right. The eye's working okay, the optic nerve is working okay, but it's getting blocked before a person can consciously experience the vision. And that manifests itself with an area in the vision that they just can't see. Yep, exactly. So if, for example, you have a visual field defect on the right side and you're looking at a plate of food and you look right at the plate of food, you'll see the food on the left side and you may ignore what's on the right side and eat only half of what's given to you. If you're sitting at a table socializing with people and you can't see the right half of your visual field, then you may have a tendency to ignore what's going on the right side of the table and just be speaking to the people who are on your left side. If you're walking down a hall and there's a cabinet on the right side and you can't see it, you may run into it. So all of those things are issues that people run into when they can only see half of the world, more or less. And good physical therapists and good occupational therapists will work with people who have that kind of visual field defect to become more aware of the part of the world that they can't see and to consciously try to compensate for it. When people have that type of visual field defect, we urge them to get up and around and walk with someone, even outside, but the person they walk with has to be on their right side because that's the side they can't see. So you really want to make sure that the person they're with is going to be on their kind of side that needs protection.
Gives a little bit of a buffer.
That's right. And when they're socializing, we urge for the people they're socializing with to all be on the side that they can see. And that makes it easier. Reading is an issue. So if you can only see half of a word, it gets hard to read. People who have a visual field defect on the right side of their vision have different reading problems than people who have a visual field defect on the left half. So people with a visual field defect on the right, for example, they can see the first half of a word and they're able more or less to realize they have to look further to the right to see the end of the word, but it's a struggle and it slows you down. It gets hard to track down a line word by word if you can't see the right half of words. So that takes training. That usually takes a speech therapist to help you kind of figure out strategies to get around it. We have people use straight edges to read with. That helps them track along a line of print. Even colored straight edges are helpful. That really makes a nice clear mark for where a person should track down to the right to read. Now, people who can't have difficulty seeing on the left-sided visual field defect, they can see the last half of the word, but not the first half. So that's a constant struggle kind of going back and forth down a line and catching the whole word. And then their difficulty is when they reach the end of the line of text. Since they don't see well on the left, they got to find the next line, and that can take time. It's a bit of a struggle. But it helps them also to use straight edges and track line to line. So people with these visual field defects can read, but it takes a lot of extra effort.
Right.
And so we counsel them.
The effort, I suppose, would be the opposite for folks who are reading at I think Hebrew or in
That's
Japanese
right.
or Chinese.
Where it goes up or down. We've actually had some people actually twist the paper so that the words go up to down. And that sometimes helps if you only see half. So it's more or less kind of like Japanese writing. Yeah, you shift it around. Yep. Mm-hmm. So those are a couple strategies. There are, for people who don't get better at all and have a pretty complete visual field defect on one side or the other, you can sometimes rig up spectacles with prisms that shift the images over in both eyes so that there's more of a seeing field in the center and not a cut right down the center. Those get kind of complicated, but they do help some people. We tend to hold off on putting prisms in glasses of people with visual field defects unless they've had it for a while and they're clearly stable and seem to be motivated enough to potentially get the therapy and benefit from that.
Interesting, because any of this medical hardware, any of these assistive devices, they're really only going to be, or to get the most use out of them, you really have to do the exercise and do the work that goes along with it. You're not just putting something on and that solves the problem.
That's right. And there are not very many optometrists who are trained to put in that specific type of prism. So we always make sure that we refer them to someone who's experienced and has done a lot of it.
It's really interesting to see how that happens. And I mean, I remember back in college reading the studies, the experiments of, if you put special glasses on people with standard vision that just flip the world upside down, it takes like a couple days and everything looks normal to them. And
it's usually 2 weeks.
Versus 2 weeks.
2 weeks, yep. Mm-hmm. Yeah. But then you take the glasses off and it flips over again. And you've got to get used to it again. It's the same with the glasses that we use for visual field defects. It's a bit of an adjustment. It throws people's balance off because it shifts the world over to one side or the other. And that can be difficult with a person who's had a stroke and may have some other neurologic problems as well. So it's a commitment, but in some people it's very helpful.
Right, right. My girlfriend didn't have a stroke, but she just became a full-time glasses wearer in her late 30s. And just, those of us who wear glasses, you're not used to the fact that they warp the world, they alter your distance, and having to adjust to that later in life presents its own challenges.
Especially after a stroke.
Yeah.
Yep.
Yeah. And then factor in everything else going on with the stroke.
Right. But it can be done. But again, we're selective about who we recommend that for because it is time consuming and it can be costly too. Right. So you don't want to just have everybody give it a try.
You're not going down to LensCrafters to get that done.
That's right. So and the other kind of stroke I was going to mention too, when it affects the base of the brain, that affects the eye movements, the symptoms that people have, like we talked about, they can get double vision if the eyes get thrown out of line, or if they develop this nystagmus where the eyes are spontaneously moving, they can feel vertigo or oscillation of what they're seeing. Same with them. The first thing is you just wait, because a lot of times those symptoms get better. And sometimes they go away completely after strokes. But if people do not recover completely from a stroke that affects the brainstem or the cerebellum and they have persistent double vision, we can put prism in glasses to correct the double vision. That's easier to do than using prism for a visual field defect. So a lot of stroke patients who have double vision get prism in their glasses if it doesn't go away on its own. When the eyes move spontaneously and they have nystagmus and vertigo, we can use medication to slow the nystagmus down if necessary. And you can also rig up glasses with prism and whatnot to treat nystagmus as well. But that's not very common.
Right. So is that similar to sort of what they use with Botox and baclofen to treat other spasticity and tone?
Exactly.
And is there ever any, surgical interventions around those muscles?
Sometimes, for example, if a person gets double vision after a stroke and the eyes are crossed, they're kind of turned in towards each other. First, we wait, like always. Secondarily, we'll put prism in glasses, and the prism shifts the image in the eyes so that even though the eyes may be out of line, the images will be lined up. And if a person is stable for an extended period of time and the eyes remain crossed, then you can actually do surgery on eye muscles to straighten the eyes out so that they're pointed together again. That way you can get the person out of prism. So again, that not usually necessary in stroke patients, but
and
occasionally.
definitely not something you want to do quickly.
That's right. You always wait before you consider something like surgery, because so many people with strokes get better,
right,
that you don't want to fix it before it's totally improved, because then you're going to be off mark and they're going to have symptoms again.
Right, like those glasses that turn the world upside down. The brain learns to reinterpret that, and if the brain can reinterpret the crossed image to a standard image,
that's right,
you're good to go.
Right.
So when you're talking about prisms and altering, special things with lenses and things like that, are they doing things with, LASIKs or other similar types of procedures that are able to accomplish that by...
For double vision?
For double vision or for other similar types of things?
Not really.
Okay.
What LASIK is good for is to change the shape of the eye to get people out of glasses, particularly nearsighted people.
Right.
But that wouldn't really help with the kind of problems that people with strokes get.
Okay.
Just regular glasses don't fix the visual field defects. It doesn't fix the double vision. So you really need additional type of interventions to help. Yep.
Gotcha. It makes a lot of sense. What usually surprises folks most about, the interrelationship between vision and the brain and the eye and how all of this stuff comes together?
I think the thing that we hear the most that surprises people is that when they develop a visual field defect, for example, if you have a visual field defect on the right side in each eye from a stroke on the left side of the brain, the visual field defect is really in each eye. It's in both eyes, but just on the right side of the world. And people who've had strokes after this happen think that the visual problem is in their right eye. And it takes them coming here and us showing them, actually, it's kind of in both eyes, just the right half, for them to realize, oh yeah, it's both my eyes. And that's the way that the brain is wired up. But that is just not intuitively obvious at all. So if you can't see on the right side of the world, people just naturally assume, well, it's got to be my right eye. But in fact, it's not. It's the right half of both eyes. And that's, I think, what we hear most common.
Yeah, and it's tough to wrap your head around that. It's like what I often say is that there is nothing wrong with my arm. There is nothing wrong with my leg. It is literally all in my head.
That's right.
And
that's exactly right.
There's nothing wrong with the right eye. It is literally all in your head.
That's right. Yeah, you're sure not making it up, though.
Yeah, exactly. Right. Exactly. Yeah. Well, except to the extent that everything the brain does is the brain is making up, and then we're getting way into metaphysics, and we don't really want to go there.
Too complicated.
That's another podcast. So, there's so much stuff we're learning now, and I'm sure there's stuff coming in from the machine learning space, and there's stuff, as we've had, obviously the upsurge in research in TBI, everything from just greater awareness to, unfortunately, the wars that have happened, which have brought a lot more TBI awareness and research. What is some of the most exciting research that you see happening in the field of neuro-ophthalmology?
Oh boy, there's so much going on now. Compared to when I was first in training in the late 80s and early 90s, neurology in general was considered a field where we would make a diagnosis and then tell a patient, well, yeah, that's what's wrong, and adios. We said diagnose and adios was pretty much it. But as the years have gone by, there have been so many interventions that have appeared with every type of neurologic condition. Particularly in stroke with the clot busters, and helping prevent more severe problems with acute treatment of stroke. But Parkinson's disease and multiple sclerosis and brain tumor infections and whatnot, there's just so many areas of treatment that were not available even 5 years ago. So we're doing a lot better in treating just about everything than we used to be, and preventing a lot of disability that we couldn't prevent before. I think what's most exciting to me is the research that's being done regarding making people better once something has already happened. So if you have a neurologic problem and it's stopped, then what can you do to make a person better? And fortunately, there's a lot of research going on into that specifically. There are compounds or medications that are available to help nerves work better that are only partially working. There are treatments to try to get myelin or the coating of nerves to reform when the myelin has been damaged for whatever reason. There's stem cell research looking into getting nerve cells to grow again. So I think that to me is most promising. I'm not sure that we're going to be seeing much of that in my lifetime or my career, but boy, it's starting, and people are really thinking about this. And the most recent work that I saw was just rat research looking at the optic nerve. Generally when a person has some sort of optic nerve problem, and from whatever reason, from blood flow or from a tumor or trauma, that we just tell them, sorry, the optic nerve can't heal up. This is the way your vision's going to be if you've had an optic nerve problem. But there's studies in rats now looking at specifically at stem cell research where they got an optic nerve to grow a millimeter. Now, that's not much, but it's more than any optic nerve has grown before that was damaged.
And it really doesn't have to go that far in the head.
That's right. Well, the problem with the optic nerve and with the rest of the nervous system is it's not so much that you need these nerve cells to grow. They have to grow in the right place and connect with the right nerve cells. So it's complicated. But, as long as research gets funded and as long as people are interested in these types of topics, and I'm sure they will be, then I think we're going to get there. But, I think that's the next phase in neurologic care and neuro-ophthalmic care is not only stopping whatever disease process is occurring, but to make people better again.
And that's one of those areas, too, where it's so important for us to keep in mind, as survivors and as the broader community, that it's not just about stroke and it's not just about TBI, but it's about all of our neurological cousins, all of our cousins in the MS and the ALS and the Parkinson's space and all of these other spaces, because ultimately the way we got to where we are is different in many cases, but ultimately we're still trying to just fix what's going on with those nerves, try to fix those connections and build those connections so we can live the best life we can.
That's exactly. Yeah. And I think it's particularly relevant with stroke, that, a person has a stroke, it comes on out of the blue, and more often than not, we can figure out why and can address the underlying problem, but then you're left with the problem, right? And that's at this point kind of what we want to make better.
Right. So much of it has been about let's keep you alive past the first 24 hours. Let's make sure it doesn't happen again.
Right.
And let's get you to PT and OT and speech because that works. But is there something else we can do?
Right.
And now that survival rates are increasing, and among younger folks, there's starting to be a lot more interest in, well, okay, so what can we do?
Right.
So, if folks want to know more about your work and what you're up to, where should they go?
Well, we're on the Swedish website. If you go to swedish.org and look up neuro-ophthalmology, that's where our practice webpage is located. There's a lot of good information on it. There's a list of medical conditions or neuro-ophthalmic conditions that are probably the most common things that we see that you can click on and read about. Including blood flow issues related to the eye and the visual pathways. So that would probably be the best place.
And we'll have links to all of that over at strokecast.com/Dr. May. And you can also find the show notes for this episode as well as previous episodes with other folks from Swedish, including Drs. Shaw and Stamen and Bronwyn over at strokecast.com/Team Swedish.
Great.
So, Eugene, thank you so much for your time today. This has been fascinating. I love learning about this stuff, and I think it's probably been helpful to quite a few people.
I hope so. I really appreciate it. Thanks for asking me.
And that brings us to our hack of the week. Use your camera phone to get into awkward spots. This is actually maybe a little bit of a cheat for me because this is one of the things I consider one of my general life hacks, not necessarily stroke specific. But since I do have more limited dexterity, mobility, and balance now, I do find myself having to do this more often. A lot of times I may need to reach into an awkward spot and not really be able to see what I'm doing. Most likely that means I'm trying to plug a cable into the back of the computer or the network router or some other piece of gear, or I'm trying to reach something that has fallen under the bed and I can't actually get my head down into the right spot to physically see what it is I'm trying to deal with. So the way I'll solve that, or address it at least, is to go ahead and use my camera phone, reach down with the phone, take a picture of what it is I need to do, and then I can look at the picture, and that gives me a much better idea of where I need to put my one fully functioning hand in order to accomplish my task, even when I can't quite see it. It's not a 100% solution, but it does help quite a bit. Another option, of course, is to also just use the phone as sort of a live mirror, so I can prop it against something with the camera and the flash going at the same time, and I can sort of look at an angle into the screen and see whatever the camera is seeing as I try to move my hand someplace, kind of using it as a high-tech periscope. So it means I can actually go ahead and plug in cables in a minute or two instead of the 10 to 15 minutes of frustration it might otherwise take. So next time you are trying to reach into an awkward spot and have to do it without being able to actually see what it is you're trying to do, go ahead and try using your camera phone to take a few pictures or video, or just sort of to provide a reflection and image of what it is you're trying to do. It may just make all the difference in plugging that cable in or digging that pair of glasses out from underneath your bed. So that's it for this week. To learn more about the field of neuro-ophthalmology, be sure to check out the website for Swedish Medical Center. You can find that link in the show notes over at strokecast.com/Dr. May. That's DRMAY. Be sure to subscribe to Strokecast for free in your favorite podcast app so you never miss an episode. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you next week.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.